Welcome, everyone, to the Neurotrauma Evidence Synthesis Training. Today we have guest lecturer Cyrus Raji, MD, PhD, and he's going to be lecturing on the neuroradiology of traumatic brain injury, and this is part 2 of a lecture series. If you were not at last week's lecture, we'll have the video posted for you. I'm going to go ahead and go over Dr. Raji's credentials again today for this video. Dr. Raji is a tenured associate professor of radiology and neurology, as well as the principal investigator at the Neuroimaging Labs Research Center at Mallinckrodt Institute of Radiology in the Department of Washington University Medical School in St. Louis. He is also the director of neuromagnetic imaging at Barnes Jewish Hospital and is the associate director of the Diagnostic Radiology Residency Research Tract. He is board certified in diagnostic radiology and neuroradiology with research interests focusing on modifiable risk factors for dementia and the role of advanced neuroimaging in quantitatively tracking related brain changes and also identifying traumatic brain injury. He's published over 100 peer-reviewed articles on advanced neuroimaging, including traumatic brain injury, and has been cited over 6,000 times. So without further ado, Dr. Cyrus Raji, thank you again for coming back.
Thank you so much for having me. I really appreciate the opportunity to speak. Today I'll be talking about neuroradiology of traumatic brain injury. This is the second part of a two-part lecture, the first part of which I began last week that focused on conventional techniques. And, to kind of recap some of the principles and information that we discussed, traumatic brain injury is an external force that often results in impaired I'm mute. I thought I was on mute, and anyway, can everybody hear me now? Is anybody not able to hear me at all? If not, please let me know, and I'll start all over again from scratch. Okay, so my name is Dr. Cyrus Raji. I'm very happy to be speaking with you today about neuroradiology of traumatic brain injury part 2. And to recap some of the principles we discussed before, traumatic brain injury is an external force that results in impaired brain structure and/or function. There were over 1.7 million cases of TBI in the US per year on average. In 2019 alone, there were 610 TBI hospitalizations and about 166 deaths per day. So it's quite common. It's quite a big issue globally. Globally, it's estimated that there are at least close to 56 million cases of mild TBI worldwide and 5.48 million cases with severe TBI. All of this to say, very simply, that mild TBI by far is the most common type of traumatic brain injury. It's also the least tracked type of traumatic brain injury clinically. We don't have a large number of TBI clinics around the country that really try to track TBI on the mild basis. Most of the cases that we see clinically in the hospital are severe or moderate TBI, and this can lead us to severely underappreciate the burden, prevalence, and consequences of mild TBI. And so again, I defined traumatic brain injury last week, but to really kind of add a lot more granularity and specificity, traumatic brain injury is an external force involving the head at a single or multiple time points. It could be one traumatic event, it could be repetitive physically traumatic events, and it can lead to a complex pathological set of brain abnormalities that could involve, but are not limited to, structural changes, changes in the actual physical size or structure of the brain, perfusion alterations, changes into how blood flows into the brain, often leading to decreased blood flow, white matter microstructural abnormalities, which could also impair the wiring of the brain, called the connectome. We can have underlying changes in the neurometabolic composition or neurochemistry of the brain. So these are the neurometabolic building blocks of neurotransmitters, for example, and cell membranes. And the reason these changes are important is that they can lead to short or long-term disability with various symptoms that may include, but are not limited to, impaired cognition or cognitive decline, the ability to remember things, to think through complex tasks, to plan out tasks, to integrate visual and spatial skills. They could lead to neuropsychiatric symptoms such as anxiety, depression, attentional deficits are another example not listed here. Very common related to TBI are arousal symptoms, including sleep and attentional issues, as well as motor disturbances. You can have issues with movement. Headaches, dizziness, and fatigue are also common symptoms ascribed and related to traumatic brain injury as well. And so again, we talked about this last week, but again, depending on the year we look at, it could be upwards of about or over 2 million cases of traumatic brain injury related events. Over 800,000 of them often include children. TBI is costly. It costs the US billions of dollars per year, $76.5 billion. To give you some perspective, the entire budget of the National Institutes of Health last year was $47 billion. And so, traumatic brain injury costs well over the NIH budget. We can talk about very crude designations of the Glasgow-Coma scale of TBI as mild, moderate, or severe. These are not the only way of classifying TBI severity. It's simply what is used in the super acute clinical setting, typically in the trauma bay, to see if there's like an overall impairment of consciousness or movement, which is essentially the different questions and observations that relate to the Glasgow-Coma scale. Of course, the most common causes of TBI are falls and motor vehicle collisions. And of course, in the kind of subacute to chronic TBI, we're often talking about less than or greater than 3 months out. So chronic TBI can be as early as 3 months out. It doesn't have to be years, although oftentimes when we see traumatic brain injury, it is often on the order of years. And so again, to kind of recap from the CDC, the biggest causes by far of traumatic brain injury are, motor vehicle accidents, falls, other causes, which can be, a variety of different elements of an event. Interestingly enough, sports, while pretty common, are not as common as motor vehicle collisions and falls. Those are by far the most common causes that we see from any one single event. And the mechanisms of traumatic brain injury that play out on a cellular level can play out immediately following the traumatic event and then can progress from hours to days, months, and then years. And so when traumatic brain injury happens, when there's a jarring force or a direct impact that causes, injury to the brain, we can see elevations of inflammatory cytokines, immune activation of glial cells, which are support cells in the brain. We can see differences in leukocyte and lymphocyte accumulation. We can see edema in the brain, which can often manifest in terms of abnormalities on a variety of advanced imaging markers. We can see actual cell death, increased intracranial pressure. We can see pathology in the axons of the white matter that connect different parts of the brain. We can see seizures. And then as these mechanisms play out over months, we can start to see early brain tissue loss or neurodegeneration. Some of the related abnormalities clinically that might develop can include epilepsy, so post-traumatic seizures are super common. We can see autoimmunity, we can see endocrine dysfunction. Pituitary dysfunction in particular is quite common after traumatic brain injury. We can see the development of type 2 diabetes, which is interesting because some people might try to claim that brain abnormalities are related to the diabetes, but if they develop in relation to the brain trauma, that's an important element to note. Depression, of course, in relationship to the neuropsychiatric consequences is also important. And then, of course, out to years, we can see evolution of microgliosis, the accumulation of Alzheimer's proteins, because traumatic brain injury is an important risk factor for Alzheimer's. We can see the accumulation of amyloid and tau plaques. We can see loss of brain tissue additionally and more neurodegeneration, more epilepsy, more cognitive dysfunction, depression. In some subsets of individuals with traumatic brain injury, like individuals playing sports with these kind of chronic, repetitive subconcussive blows, we can see chronic traumatic encephalopathy. And yet, in many other individuals, we can see the development of dementia and Alzheimer's disease, as well as the evolution of post-traumatic stress disorder, which people talk about that as being related to emotional trauma, but emotional and physical trauma travel together. And so individuals with traumatic brain injury often have post-traumatic stress disorder. And, to kind of go more into the idea of how traumatic brain injury can give rise to Alzheimer's pathology, we know that mild traumatic brain injury can give these variable post-concussive symptoms. And of course, mild repetitive TBI or moderate or severe TBI is more tied to Alzheimer's disease development, including these abnormal amyloid and tau plaques that we can note as well. And if somebody has a pre-existing genetic risk for Alzheimer's disease, such as the ApoE4 allele, of course, that will add on and increase the vulnerability to the traumatic event and thus the subsequent Alzheimer's risk. Now, when we talk about the brain, of course, we can divide the brain very broadly. I mean, the brain has a lot of neuroanatomical distinctions, but the broadest kind of way to kind of categorize the brain, of course, is left brain, right brain. But of course, within the brain itself, on each side, we can also denote organizationally different lobes of the brain, the cerebellum, the brainstem. And of course, the reason it's important to note the neuroanatomical distinctions is because these different areas of the brain subsume different functions. And so the frontal lobe, of course, is important in focusing on concentration, problem solving, speech. And so if there's a traumatic brain injury, injuring the frontal lobe, there can be a lack of focus, irritability, and language difficulty. The parietal lobe, very important part of the brain that's affected in Alzheimer's disease. It subsumes the sense of touch, pain, temperature, but it also integrates visual, spatial information into cognitive function. And so if there's a parietal lobe injury, one can have difficulty with reading and spatial perceptions. Occipital lobe damage, of course, can impair vision, which can lead to blind spots and blurred vision. Temporal lobes, super important for memory and learning. And so if there's temporal lobe damage, and the temporal lobes, along with the frontal lobes, are among the most injured areas in traumatic brain injury, areas of abnormalities in the temporal lobe can lead to problems with short and long-term memory. The cerebellum is important for balance and coordination. And so, of course, if there's difficulty with the cerebellum and injury there, one can see difficulty in walking and slurred speech. And of course, the brainstem, of course, is important in breathing, steady heart rate. It's also important in arousal as well. And so changes in breath and swallowing, but also potentially issues with arousal and sleep disturbances can also be seen in brainstem injuries as well. And so this was a paper published 10 years ago by Dr. Yoshimi Anzai. She's actually the current president of the American Society of Neuroradiology. And even though this paper is upwards of a decade old, even back then, there was this focus on making the invisible visible with imaging of traumatic brain injury. And what she writes here, and what I wanted to highlight and read to you, is that the problem of mild TBI has imposed much frustration among neuroradiologists as conventional structured imaging studies fail to reveal abnormalities despite patients' symptoms. So patients are symptomatic, is what's being written here, and conventional imaging won't actually reveal abnormalities. As imaging experts, Dr. Anzai writes, we want to make invisible disease visible so that either proper treatment is provided or patients are assured they may return to their normal activity or sports. And so, of course, people aren't just professional athletes. They have jobs, they have lives, they have things they have to do to stay functional. And so it is important to actually track the extent of injury in the brain in order to really understand what the prognosis is and what the related required treatments might be as well. And of course, this is not a new idea. This is not an idea that we just talk about with traumatic brain injury, right? We talk about it with other conditions in neuroradiology as well, and neurology, such as epilepsy. And so, of course, epilepsy isn't always due to traumatic brain injury, even though there's a tight link between the two. Epilepsy can often arise due to other reasons. They can be congenital, they can be due to other, kind of underlying causes. But the idea that we can use advanced neuroimaging, imaging that goes beyond conventional structural assessments to identify abnormalities in the brain, is something that's been written about in other literature. And so this was a review article published in, Frontiers of Neuroscience. And it's important to read some of the text here because it is helpful to understand. But, what's written here is that our title is called Making the Invisible Visible, Advanced Neuroimaging Techniques in Focal Epilepsy. So again, the idea behind making the invisible visible, what does that mean? That means we're using advanced imaging to measure something about the brain, such as atrophy, blood flow, white matter, connectivity, or structure that we can't readily see with the naked eye with gross visual inspection. That's the idea behind making the invisible visible. And so what they write here, or what this individual writes here is, on the other hand, epileptogenic lesions, that's lesions that can cause epilepsy in the brain, sometimes show only subtle or even invisible abnormalities on conventional sequences. This is not an article about traumatic brain injury, just to interject. This is an article about epilepsy by itself, not related to trauma per se. And so this individual goes on to write, and thus efforts have been made for better visualization and improved detection of the focused lesions. And what they also write is recent advances in neuroimaging has been attracting attention, including Gaussian diffusion model and arterial spin labeling could non-invasively detect decreased neurite parameters or hypoperfusion, that's low blood flow within focused lesions. Advances in analytic technology may also provide usefulness for both focus detection and understanding of epilepsy. And so again, we reviewed this last week, but I think it bears repeating. Conventional MRI is better than conventional CT. So again, these are conventional structural sequences that we can evaluate with our, kind of naked eye as neuroradiologists. And neuroradiologists are trained to try to identify subtle lesions visually. But if it's not detectable to the threshold of the human eye, the radiologist, no matter how good they are, isn't going to see it. And of course, that's a lot of these injuries. And so again, what's written here is in assessing long-term outcome for mild TBI, there's essentially no role for conventional and MR findings, as the findings are frequently normal in this setting. So again, what does that mean? That means that if an individual has a conventional CT and MRI without advanced imaging, without quantification of any advanced techniques, and the scan is called normal, all that means is that the neuroradiologist or the radiologist, because it's not always a neuroradiologist looking at the scan, examining the scan cannot see anything that they can visually identify as abnormal that they can report. But that doesn't mean there isn't more subtle disease that could be detected with the right combination of advanced imaging and related quantified approaches. So that's very, very important to understand right off the bat. And again, we see this in medicine time and again. There may be somebody who's not obese, who doesn't have type 2 diabetes, who doesn't have, hypertension, but for genetic reasons or for other reasons environmentally, they may have occluded coronary arteries and they could get a heart attack. So again, just because we can't see it blatantly on somebody or on the conventional assessments we have, doesn't mean there isn't disease that we can't detect. And in the history of medicine, we've often had the issue of trying to improve detection as opposed to having too much detection. And of course, conventional and advanced imaging entails a variety of techniques. Conventional sequences tend to be revolving around different types of weighting. So there's T1 signal that emphasizes brain structure. There's T2 signal that looks more at white matter and fluid signal. Those are conventional sequences. Fluid attenuator diversion recovery is an example of that type of weighting on the T2. And of course, as you move from those conventional sequences to diffusion tensor imaging or DTI, we can start looking at the neural wiring of the brain. We can look at arterial spin labeled or ASL MRI to look at blood flow. Functional MRI looks at the blood oxygen level dependent coefficient, or how demagnetized or deoxygenated blood might become as it's being tracked in the brain with activity. That is a harder signal to capture, so we don't talk about that so much, but it is used clinically. And then, of course, there are nuclear medicine techniques that could potentially be used to track abnormalities in TBI or look at long-term consequences, like with amyloid PET. However, we don't use PET to assess traumatic brain injury because there's limited access for PET scans in the United States. There are only about 2 million PET scans done per year. Most of those are done for oncologic assessments. And then, of course, you compare that to MRI, where we can do upwards of 40 million scans in the United States without radiation. And of course, as I'm going to be talking about traumatic brain injury, none of these assessments require the use of any sort of contrast agents whatsoever. And so it is truly the most minimally invasive, high-resolution imaging test we can get for a patient that's also widely available to patients at the same time. And so hopefully that provides some important context. So again, qualitative imaging or visual assessments versus quantitative or measurable imaging. So again, conventional imaging, think visual evaluation. It can miss a lot of things, especially with TBI and mild TBI. Advanced imaging means measurable imaging. These are things that we can actually measure and also sometimes see, but more reliably we can measure them. And those are very useful for detecting evidence of traumatic brain injury, especially mild TBI. And so again, the two kind of core sequences that we tend to talk about with advanced imaging includes structural imaging with volumetric sequences. That means that we can acquire a high resolution anatomical scan of the brain that covers enough area where we can actually take the three-dimensional pixels of that scan or voxels and use that to separate, segment, and measure the individual brain areas as well as the overall lobar structures and compare them to normative data to determine whether or not there is subtle evidence of brain atrophy that might not be visible to the actual naked eye. And that's structural imaging with volumetric quantification. Sometimes people call it volumetry or 3D volumetry, but the principle is that we're using high-resolution structural scans to measure these individual brain areas. Functional scans with perfusion MRI or arterial spin-labeled MRI gives us the ability to look at the actual blood flow in the vessels, especially out in the gray matter and the cortex where the neurons are housed. And with that, we can create blood flow maps of the brain. And so this color map you're seeing with the red and yellow colors and some of the green colors, that shows higher blood flow in the brain. But we can also compare it to normative data and identifying these blue colors overlaid onto a structural scan, subtle evidence of abnormally low blood flow in the brain that, again, we might not be able to appreciate with conventional visual or qualitative assessments. And so what's an example of that? Well, sometimes we can even fuse form and function to get overlays of the brain. And so you can see a structural MRI in an individual. You can see an ASL perfusion map with color scaling. You can actually merge these two scans together to see the exact anatomy of the abnormally low blood flow into the brain. And we can see that both, grossly, but also with greater anatomical precision, we can see that there is reduced blood flow, in this case, in the right frontal lobe. And again, this is radiological assessment. So again, it's a paired opposite compared to what you see in the conventional reading. And of course, we can see on this another individual who had traumatic brain injury. So this individual had a traumatic brain injury, motor vehicle collision, as I can recall. This individual also had, I believe, a rear end collision. So they hit the back part of their head, and you can see low blood flow in the back part of their head. But you can also appreciate on the statistical map additional areas of low blood flow that wouldn't otherwise be appreciated. And you kind of see this classic coup counter coup injury where, again, in neurological convention, the left frontal lobe is worse than the right frontal lobe, but you can see that there's this really asymmetrically worse area in the right parietal lobe. So again, that coup counter coup that I showed last week, where you can have an initial point of impact, and then of course the counter area of injury as the brain shakes around in the skull and the cerebrospinal fluid is even worse than the initial point of impact. That's the coup counter coup. And we see a lot of evidence of that in the cases that we've encountered. And again, this is just another example of showing that asymmetry, especially in that frontal area. But we can do more than assess even brain structure and blood flow in the brain. Blood flow, again, is really important because it can be abnormal even before you see brain atrophy. But the most vulnerable and most frequent area of damage and traumatic brain injury is the white matter. And so we can assess white matter connectivity with diffusion tensor imaging. We can look at the microstructure of the white matter. And so all of these kind of red and yellow and green areas, that's the white matter of the brain connecting the gray matter. The gray matter is dark because that's not the area that's being highlighted. And you can actually take a feature of white matter microstructural integrity called the fractional anisotropy, or FA. There are other things you can measure as well, but we won't go into those so much because the FA is the most sensitive area of microstructural abnormality in traumatic brain injury in particular. And it refers to or describes the movement of water along white matter tracts. And so when that movement is impaired because the white matter tract is damaged, we can see abnormally low FA. And so this is an individual who got a diffusion tensor imaging scan, and then they received an analysis with an FDA-cleared software called IMECA. and you can compare that individual's DTI to a normative database. And when you do, you see that there's this asymmetrically lower area of white matter tracts on the left side of the brain. You can see that it's below the 5th percentile, and it's completely asymmetric on the left side. And it turns out this individual's point of trauma was worse on the left than on the right. And we can see that these areas are all below the 5th percentile. And so that's important because we're able to then see that these are important areas that are affected. And they include, the cingulum, the longitudinal fasciculus, the corona radiata, and again, really targeting areas that are affected primarily in the frontal and as well in the parietal lobes. And so that's a very important kind of point of assessment that we can use this technology for. We can also, in some cases, even look at metabolism with neurochemistry with MR spectroscopy. MR spectroscopy looks at the unique resonance frequency of different metabolic building blocks in the brain, such as N-acetylcysteine, choline, glutamate, and glutamine, and they resonate differently, sort of like the way different musical instruments have different harmonic resonances. And you can use that information to measure how much of these actual metabolites exist. And so you can take regions of interest and measure these. This is probably the part of the scan that we don't do as much because it's more technically challenging to do in terms of just what scanners have the ability to do it. Newer scanners tend to have a better way of doing it than older scanners, although older scanners can do this as well with some modifications. And so that's another example we can get. So we've talked about with measurable or quantitative imaging structure, connectivity, and metabolism. But even from data like structural scans, we can look at other features that can denote and help us understand the extent of disease. So for example, we can look at something called brain age. Brain age refers to the ability to take a brain scan, measure the individual volumes on high resolution 3D T1 volumetric sequences, compare that to normative data, and ask and answer the question, does the actual age of the brain scan align with the chronological age of the individual based on how large we would expect brain areas to be for somebody of that chronological age? And if the answer is the brain age looks older than the chronological age, we have a positive brain age gap, which means we have accelerated or abnormal aging. If, of course, the brain age is about the same as the chronological age, then there would not be a brain age gap and there would not be accelerated aging. And of course, it is theoretically possible for people who have really good, healthy lifestyles that you could potentially even have a negative brain age gap, which means that you're aging in reverse or you're decelerating your aging. Although, unfortunately, with most pathological conditions, we would expect to see an elevated brain age gap. And it is elevated in chronic traumatic brain injury, as noted in this paper from 2022. And it's noted particularly as greater in chronic traumatic brain injury. So why is that important? Why is it important to know about brain age and accelerated aging? Well, because age is the biggest risk factor for Alzheimer's disease and neurodegenerative conditions. So if there are problems that are accelerating brain aging, such as traumatic brain injury, we should know about that for individuals who have these conditions. And so this is an example of an individual who had a brain age assessment off of their T1 weighted scan. We can see that their chronological age was 54 years of age and that their brain age estimation was 59.86. And so what does that mean? That means this individual is almost 6 years older than their chronological age. They have a positive brain age gap. They're aging in an abnormally accelerated way. And that's evidenced by these charts that show the brain segmented out with red colors, denoting all the parts of the brain that are abnormally aging. Again, this individual is 54 years old chronologically. If they had a brain age in alignment with their chronological age, all of this should be green. If they were younger than their chronological age, it could be blue. And because they're abnormally aging, it's all red. And that's a problem. And we can see that in this individual that we can not only identify brain age on the whole brain level, but we can look at individual brain areas and again, ask and answer the question, is there abnormal aging in particular areas that, for example, might be vulnerable to Alzheimer's disease? And the answer is absolutely, there's a higher chance of that. For example, look at the entorhinal cortex on the left and on the right. The entorhinal cortex is the gateway to the hippocampus. It is the earliest affected area in Alzheimer's disease. However, Alzheimer's doesn't start until age 65 on average, and this individual is 54. So what's happening to the entorhinal cortex? Well, it has an abnormal brain age of 63 years and such on the left and about 62 years on the right. So upwards of almost a decade older than this individual's chronological age of 54. But that's not all. We can see that the posterior cingulate gyrus, another area that is affected by Alzheimer's disease, is upwards of close to a decade older than this individual's chronological age. The parahippocampal gyrus, again, 5 to 7 years older than the chronological age. The precuneus, again, another important area affected by Alzheimer's disease, solid decade older on both sides compared to this individual's chronological age. And this individual did have a traumatic event with a motor vehicle collision. And so to see this accelerated aging is super important because it suggests that this person is at a future higher risk of Alzheimer's disease because Alzheimer's disease is subsumed in its risk by aging, and this individual clearly has accelerated brain aging, particularly in areas that we know based on the neuropathological literature are vulnerable to Alzheimer's disease. And so this is somebody who clinically would have to be followed up over time to make sure that they're either cognitively stable or if they're developing a cognitive decline that's even worse than expected from their injury, would have to have more closer assessments for underlying neurodegeneration and Alzheimer's disease. And because we now have treatments for Alzheimer's disease, it actually is important to know this information because we could actually do something about this. And so again, this is an example of the brain aging in this individual. Again, if it was a regular brain age of 54, it should be all blue. It's all yellow and red on many areas because again, we see this asymmetry in particular related to the kind of counter-coup injury. And again, this accelerated brain aging overall into the 60s, which again, far too abnormal for an individual of in the 54. We can also look at something called the disconnectome. So again, even though it's important to know about white matter microstructure, which is what the DTI gives us, we can also look at FLAIR imaging, and we can ask the question, are there lesions that can give us insights into areas of the brain that are disconnected? And the answer is yes, we can. And the reason that's important is because we can identify parts of the brain that are disconnected based on the disruption in white matter tracts. And so this is another individual who had a traumatic brain injury where we can see multiple areas of the brain with high probabilities of disconnection in major white matter tracts, including the cortical spinal tract, which is important for movement, the optic radiation, which is important for vision, the corpus callosum body, which we know is affected by traumatic brain injury, the corpus callosum tapetum, also affected in traumatic brain injury. And so again, this is important to know because this can also be a more sensitive way of tracking potential functional consequences clinically, as well as the overall burden of abnormalities in the brain related to traumatic brain injury. And so again, when you look at quantitative or measurable imaging, we're able to get brain structure, both in terms of raw brain volumes with FDA-cleared software like NeuroReader, and brain age calculations to see if there's accelerated brain aging. We can look at perfusion in the brain or cerebral blood flow. We can look at connectivity with white matter microstructure as well as disconnectomes. And all of this information can be acquired in one 30-minute MRI scan. And these MRI scanners can run all of these sequences out in the community. You don't need a specialized research scanner that's super expensive to do this. This is readily available. And again, having this measurable or quantitative imaging also adds a lot more information that the qualitative or visual assessments simply can't provide. And what you'll also notice is that each of these techniques is complementary, providing convergent validity of abnormalities by looking at different domains of the brain, whether it's the physical structure of the brain, the physiology of the brain with perfusion, and the underlying connectivity of the brain, which we know is particularly vulnerable to traumatic brain injury. And so there's been a lot of interest in TBI, not just in the United States, but also worldwide. This was a special issue of traumatic brain injury that was published last year in Biomed Central Neurology, which is a peer-reviewed medical journal on PubMed on the National Library of Medicine website. And this was a special issue with guest editors from Norway, from New Zealand. There was one individual from Stanford. And the reason I emphasize that is because, even though there's controversy about traumatic brain injury in the United States because of, National Football League and medical legal issues, in Norway and New Zealand in particular, those are not countries that are known either for, medical legal controversies or playing, American football. And so they come at it with a very impartial perspective in terms of their interests. And that's important to note because, again, we can see that the understanding of traumatic brain injury does require advanced imaging and related insights. And so they had an opinion editorial that they wrote kind of to introduce this special issue. And I'm just going to read this to you. Again, this was published in 2023, but again, it kind of reflects the work that Dr. Anzai published way back in 2015, where she said, and in many ways, this editorial echoes, computed tomography and magnetic resonance imaging are often conducted in hospitals after TBI. In many instances, these brain scans are often deemed as, quote, normal, particularly in people with mild TBI. However, contemporary neuroimaging techniques and methodologies, including functional MRI, EEG, MEG, diffusion MRI, susceptibility mapping, and of course, they don't mention this here, but also ASL, are promising in enabling detection of subtle abnormalities in people with TBI. So again, whether you're talking about a neuroradiologist publishing on this a decade ago, or people from other parts of the world publishing on this a couple of years ago, we're all getting to the same conclusions, which is that we can get a lot of insights from advanced imaging on TBI that we can't get with conventional sequences. And of course, we published our own work in this special issue in 2024, where we actually took medical legal cases that I've been, involved with as an expert, but also that I've worked on with my colleagues who are not involved on those cases, but are experts on advanced imaging. And so these include individuals like, Dr. Hongjiang Liu from Johns Hopkins, who's an arterial spin-labeled MRI expert, Dr. Alex Lin from, Harvard, who's an expert in MR spectroscopy, individuals who are experts in neuropsychology, such as Aaron Bigler. And really, the reason we did this study was because we had advanced imaging in these forensic cases. And because forensics is a point of controversy, we wanted to ask the question, okay, well, how many abnormalities do we frequently observe on these advanced techniques? And nobody had published that before. Nobody had studied the forensic population before. And so we had 65 individuals. We looked at individuals who are on average around midlife in age. So again, between 40 and 60 most commonly. We had a pretty good representation of men versus women. Most of the TBI was mild TBI, as expected based on its population prevalence. These were, individuals who are frequently months to years out from their traumatic brain injury. And the most common cause of the TBI that we frequently saw were motor vehicle collisions, specifically rear end collisions, typically. And we used FDA-cleared programs in this paper, IMECA, Brain Reader, with NeuroReader, BrainSpec. And what we found was, in looking at the NeuroReader, we noted that, the vast majority of individuals, virtually all the individuals we looked at, had abnormally low brain volumes based on the NeuroReader index, which we use because it's a more sensitive way of characterizing Z-score abnormalities because it accounts for the size of the normative database. And we found that the areas that were abnormal included, the hippocampus, the ventral diencephalon, the lobar structures, the temporal lobes in particular. 2/3 of individuals with TBI had temporal lobe abnormalities, for example. And so we did find that those were frequently abnormal areas. Lateral ventricle abnormalities or ventricular enlargement, also very common after traumatic brain injury. So that was also another common observation. And again, this replicates data that we published also in a separate non-medical legal TPI cohort way back in 2019, where we identified abnormally low brain volumes based on the NeuroReader index in total gray matter volume, the ventral diencephalon, the subcortical structures, as well as the temporal and frontal lobes. Of course, when we look at the frequency of participants with the abnormal neuroreader index for advanced imaging as separated by mechanism of TBI, we also noted that there wasn't a big difference between motor vehicle collision versus non-motor vehicle collision. Although we did note that in individuals with, non-MVC TBI, there was a frontal lobe difference in the gray matter volume as well as the temporal lobe. But otherwise, across most regions, there wasn't much of a difference. And so when people try to ask, how can you ascribe abnormalities to the mechanism of TBI, whether it's MVC or non-MVC, in both cases, there's extensive brain atrophy that we can observe. Of course, when we talk about, in the medical literature, the categorical distribution of brain atrophy determinants and their diagnostic imaging clues, when we talk about focal atrophy, such as, asymmetrical ventricular dilatation or focal lobar involvement, trauma is the most common cause that we can identify. Now, there are other causes too, but these are not causes that we often see. So, for instance, radiotherapy is a possibility, but we don't see that in these populations of individuals referred on the medical legal side. It could potentially be ALS, but they'd have to have the related symptoms to prove that. Alzheimer's disease, of course, that's a bit of a chicken and egg phenomenon because trauma increases the risk for Alzheimer's disease or a brain tumor, for example. If you have hemiatrophy, for example, or asymmetric atrophy, again, trauma, very important cause right there in adults in particular. And then other areas would have to include things like, ischemia or stroke or some pediatric syndrome from childhood, which again, we don't really see. And so again, in this paper, we looked at abnormal blood flow, both visually as well as with Z-score maps. We looked at fractional anisotropy. We looked at magnetic resonance spectroscopy. We didn't do brain age in this paper, although it's something we could certainly do in the future. But the point is that we were able to see that these abnormalities were quite common across all these techniques. Most common was actually ASL, followed by, magnetic resonance spectroscopy and the neuroreader volumes. FA was abnormal too, but we had a combination of a region of interest approach. We couldn't do IMECA on all of these participants, although the IMECA tended to be more abnormal. And of course, what you're seeing here with the ASL is you're seeing these asymmetric areas of abnormally low blood flow, and you're seeing it across different categorizations of the blood flow. And so, this is the entire cohort right here. These are all the individuals, all 65 we looked at, and you can see there's asymmetry in the blood flow, particularly on the right frontal lobe compared to the left parietal lobe. That's the coup counter coup injury. You can see that that pattern is preserved with motor vehicle collisions. So motor vehicle collisions have more of this coup counter coup pattern. If you look at the non-motor vehicle collisions in part C, the abnormally low blood flow is asymmetric. There's more of it clearly on the left side than on the right side. But at the same time, it's more bilaterally present. And so we can get some insights on the blood flow in understanding abnormally low ASL, and that is insightful from that standpoint. Obviously, we can see abnormally low blood flow with ASL, regardless of the mechanism of TBI, but the patterns do differ. And again, we can see an example of these 3D maps showing the abnormality in terms of the entire cohort. We can see the asymmetry. We can see that the Z-score maps projected onto the structural brain are shown in these kind of abnormally low Z-scores. We can see the kind of, non-motor vehicle collision, TBI, more bilaterally symmetric in the presentation and abnormalities. And that's also quite insightful as well to see. And these 3D maps with the videos are actually pretty helpful in terms of, conveying this to lay audiences. Of course, we can see again this kind of, MVC only mechanism, and that's also super important to have as well. But that's not all. We can again look at abnormally low FA with IMECA, which again compares DTI images to a separately, characterized normative database. And what it does is the program not only shows you the top 5 abnormally low areas of fractional anisotropy and can display them here in the FA percentile, here being below 5th percentile, but it looks at 33 white matter tracks. And it also compares, or at least categorizes the percentage of abnormality in all these bundles. And so this is an individual who had 5 really abnormal tracks, but 15 out of 33 bundles outside of the normative range. Now, if somebody wanted to claim that out of 30 bundles, on a bell curve, maybe like 10% of these might be due to completely to chance, then maybe we might only see 3 randomly abnormal white matter bundles in a given individual. But 15, over almost half of the bundles, that's not just due to chance. And so I think that's why it's important to note these abnormalities. And again, the idea of multiple comparisons is kind of a bit of a spurious concept to apply here, because multiple comparisons typically apply to independent observations. But last I checked, based on all the neuroanatomy, neurophysiology, and neural connectivity, the brain is inherently connected to different areas. And so these are not independent observations, because these areas aren't independent of one another, biologically speaking. And again, using the IMECA on a subset of 21 out of the participants we noted that there were abnormalities in the fornix in particular in 2/3 of the sample. We saw abnormalities in the optic radiations as well as in the corpus callosum in about 80% of the sample. The corpus callosum is the most abnormally injured area in traumatic brain injury, so it makes sense that that's the most abnormal area to see. And then, of course, the fornix is very important for memory functioning as well. So that's also something that we noticed in the highlighted areas. And again, like I said, IMECA is FDA cleared, so it actually can be used in individuals. This has been true now for almost 2 years. This is not new. And of course, we can see additional evidence here from the FDA filing. And so again, in the text of the paper, what we wrote in conclusion, because again, people talk about the American College of Radiology, papers on advanced neuroimaging and TBI. And what we write here is that official guidelines from the American College of Radiology on the application of advanced neuroimaging and TBI are almost a decade old. They're now a decade old. They were almost a decade old last year, and do not reflect the comparatively recent innovations of these FDA-cleared programs, such as NeuroReader, such as IMECA, such as BrainSpec. Thus, if an individual with TBI shows abnormal quantitative neuroimaging results across all metrics measured, such as structure, brain volumes, perfusion, ASL, brain connections, DTI, or brain metabolites, MRS, such confluence or convergent validity makes it highly unlikely that all of these results are simultaneously artifactual. I mean, what are the actual chances of an individual having all these abnormalities just due to chance or artifact alone? And I would say with TBI, we know that that's not true based on all of the thousands of papers published across the last 3 decades. So again, the American College of Radiology appropriateness criteria, which is now from 4 years ago, says that an MRI of the brain without contrast is usually appropriate for looking at subacute or chronic head trauma with unexplained cognitive or neurologic deficits. And again, all of the advanced techniques I talked to you about are examples of advanced neuroimaging without contrast. And so MRI of the head without contrast could include these as well. Again, people talk about appropriateness versus the relevance of imaging. That's an increasingly understood concept. And again, relevance implies an underlying condition, comorbidity, or risk factor. And so again, I think that that's important to note, because relevance to the condition, when you know there's a physical trauma, I think is important in selecting imaging, and in particular advanced imaging, to better characterize these abnormalities. Also, despite the ACR paper being published a decade ago, noting caution in evaluating individuals with DTI, we see now in this basic resident textbook for radiology published last year and focusing on neuroradiology, that the editors of this book, including Dr. Wintermark, who authored the original ACR paper, do note that the clinical applications of DTI can include traumatic brain injury and diffuse external injury, noting decreased FA values. Now, they do note that it is, challenging to extrapolate and apply results from a population to an individual, and they note that that's why DTI is not routinely used in clinical setting for this condition. However, now that we have FDA-cleared software with IMECA that can characterize these abnormalities, and we can obtain convergent validity from other types of advanced imaging techniques, I would say that it becomes easier to apply these techniques in combination. And I agree, it might not be the best idea to use just one technique to the exclusion of others, but I think the combination does improve that convergent validity and related interpretations. And again, this is an example of a case where we know there was a traumatic brain injury on conventional imaging seen by this abnormally low volume in gliosis, and we can see abnormally low blood flow in the same areas. The Z-score map from the ASL analysis shows additional areas of abnormality. And we can see that in the kind of 3D video rendering as well, showing this asymmetry, but kind of worse extent of low blood flow in the ASL. We can see that in the ASL analysis, there were 13 out of 33 abnormal bundles, including in commonly injured areas in the frontal and temporal lobe white matter tracts. This is a different case where there are absolutely no abnormalities whatsoever on the conventional sequences. So this is truly invisible traumatic brain injury. This individual also was in a motor vehicle collision, but there's no structural evidence of it whatsoever. If a radiologist were reading these representative sequences, they might call this completely normal looking. However, on the DTI analysis, this individual had almost 80%, 26 out of 33 bundles abnormally affected on the fractional anisotropy, the majority of which were in the left hemisphere, and the top 5 of which were well below the 5th percentile. These are large white matter tracts. This is posterior body of the corpus callosum, inferior longitudinal fasciculus, optic radiation. And so, again, if we were just using the conventional sequences, we would miss this, but the DTI adds a lot more information and value to the case. ASL also shows abnormally low temporal as well as parietal low blood flow, even evident on the non-processed, non-statistically analyzed color maps, which we can see quite easily here just through visual inspection. Of course, the disconnectome map shows that there's abnormal disconnections, with the most disconnected area being in the left anterior cortical striatal tract. So again, more of a left-sided predominance in the most disconnected area. Brain age in this individual, almost a decade accelerated compared to the chronological age. This individual's chronological age is 46 years old, and yet their brain age is almost a decade older. That is highly problematic because now this individual has a higher burden of brain aging and, as a result, a higher risk of dementia because, again, like I said, age is the biggest risk factor for dementia, and brain aging is observable on this scan. And again, when we talk about risk of Alzheimer's disease with dementia, different studies show the kind of same conclusion, which is elevated risk. The reason I like to highlight this study in particular is that people like to try to understand TBI consequences in terms of was there a loss of consciousness or not. But what this study in the Journal of Neurotrauma showed is that it's not traumatic brain injury with loss of consciousness that necessarily increases the risk for dementia, but more accurately, it's traumatic brain injury with chronic deficits or dysfunction that has an odds ratio of triple the risk for dementia. And so if an individual doesn't have any loss of consciousness with their TBI, but they have chronic deficits, either cognitive, neuropsychiatric, arousal, symptomatically, that's more predictive of a higher risk of dementia in the future than any loss of consciousness at or around the time of injury. And so that's an important thing to note as well. And so in summary, traumatic brain injury can be more accurately characterized with advanced or measurable or quantitative imaging across different domains of brain structure and function, be it volumetric, ASL, diffusion, connectivity, disconnectome, or neurometabolites, and artificial intelligences approaches, which is in the realm of translation right now with brain age, can also give us better insights into future risk of Alzheimer's disease. And so for that reason, we need to leverage these techniques for better evaluation of traumatic brain injury for the individuals who suffer, unfortunately, from this condition. And with that, I'd like to thank you all for your time. And these are my references. And thank you so much.
Thank you, everyone, for attending. Fantastic lecture, Dr. Raji. I know you're on a tight schedule today. Can you remind me if you have time for a few questions? Or do we need to go ahead and end the meeting?
I could take a few questions, sure.
A few questions, fantastic. So we've got some great questions today. The first question is there a way to measure possible damage caused to brain function that relates to a cervical injury that interferes with blood flow to the brain or cerebrospinal fluid to the brain, such as a C1, C2 ligament injury that affects the jugular vein, vagus nerve?
I mean, I think that in somebody with a high enough force of trauma to have that injury, you will definitely have abnormalities in the brain. One area that you could try to look at on the DTI, for example, is abnormalities in the cortical spinal tract, because the cortical spinal tract will course into that cervical confluence around C1, C2. And if it is damaged on the DTI based on low fractional anisotropy, that could conceivably be correlated to the cervical spine injury as well. There's not a way to track cervical spine blood flow specifically, so that would not be as easy to track. But if you had cortical spinal damage, what you would expect to see is secondary or related cortical dysfunction, which you could then note with the ASL MRI at the same time as well.
Okay, perfect. This next question is an excellent question, and it gets to the heart of primary versus secondary brain injury. When there's a clear effect showing a coup contra coup area of damage, and there's also other areas, distal areas to these regions, what is happening that so many other lobes show damage simultaneously? Is this progressive damage downstream from the initial impact, or is it related to the initial impact?
Well, the initial impact does lead to the changes in the brain in terms of shaking of the brain and the skull. And so again, when you talk about, say, acceleration, deceleration injury, which may or may not entail a direct impact to the brain. Sometimes it does, sometimes it doesn't. But regardless of whether it does or not, the brain is shaking within the CSF, within the skull, and hitting the different, you know, internal bony ridges of the skull. And so that explains why there can be such a heterogeneous, asymmetric, but still bilateral distribution of different areas of lobar damage in traumatic brain injury. And so in some cases where that happens, especially if it's more severe, you can have what they call second injury phenomenon, where there's evolution of brain contusions and hemorrhage that get worse in the first week out from the initial day of accident CT. But even if you don't see that, there is, the multiple areas of the lobes that are affected, which can then be chronically abnormal over time. And this can manifest with abnormal connectivity, abnormally low blood flow, of course, brain aging, which can be asymmetrically distributed in that pattern of injury. And so you would really have to look at all of those different factors over time to better track the extent of abnormalities and how they might be related to the injury.
Good. I'm going to select two more questions because I know we're on a tight timeline. And these questions, what I think will be most beneficial for the group. The first is a clinical question, which is someone with a remote TBI, looks like a decade, who's still symptomatic and experiencing sequelae. Will this technology be beneficial for guiding treatment and therapeutics presently?
I believe so because, for example, with brain age, and structural changes, those are the most lagging indicators of brain dysfunction. They take the longest to develop. And so you would definitely be able to track those abnormalities out over time, even if it's out to a decade. And so, yes, I do think that these techniques can still be quite helpful. But of course, the advanced techniques will also likely reveal abnormalities at the same time.
Okay. And now we have one about acquisition of the imaging on a 1.5T scanner versus a 3T scanner using these techniques specifically.
Yeah, I think that 1.5T acquisitions are certainly possible because both 1.5T and 3T are considered high field imaging, scans. The normative data of the NeuroReader as well as the IMECA include both 1.5 as well as 3T. It is possible to do ASL at 1.5 Tesla as well. In fact, we've done high quality research with that at the University of Pittsburgh as far back as 15 years ago. So it's certainly possible to do. You will hear about 3 Tesla being more popular only because theoretically you will see a higher signal to noise ratio and you can detect abnormalities so easy. So the disadvantage of using 1.5T, the error that you would have with 1.5T is that you might be underestimating the amount of abnormalities you could be detecting compared to 3T. And that's the main potential drawback with 1.5T. But could you do it at 1.5T? Yes, it's absolutely possible.
Okay, Dr. Raji, I'm going to throw two more short questions because they're really important ones. This has to do with the age range for the different normative data. What ages is this available for? And then there's a question about adolescence in here.
Most of the normal databases are done in adults. Within that bin, some normative databases are across the adult lifespan, but some are more for older age groups. I don't know of a tool that necessarily focuses on pediatric TBI specifically at this point. However, I do think if they could develop such techniques, it would be quite valuable to have.
Okay, and the other one here, a very important question about traumatic brain injury and sleep apnea. Is there any way to differentiate between traumatic brain injury and sleep apnea? It says in the brain aging study or other studies.
Well, again, with TBI, what we notice is that there is asymmetry in the abnormalities that we know, whether it's on conventional imaging in the severe cases or even on quantitative imaging on the mild cases. And so that's the main thing. Sleep apnea, the idea behind how that could potentially cause brain abnormalities is because you're starving the brain of oxygen because there's not enough air getting through the airway during sleep. And so that should lead to more bilaterally symmetric abnormalities in the brain. And again, that would not fit with what we see with a traumatic brain injury pattern.
Okay, fantastic. Well, I think we'll leave the questions at that for today. There were a couple other questions. Feel free to email me or I can be in touch with you on those questions, those of you that posted those questions. Thank you very much, Dr. Raji, again, for an amazing lecture. We're very grateful that you've spent time with us today out of your busy schedule, and wishing everyone the best. This lecture has been recorded and will be posted to the Nest YouTube video channel, and we'll give you guys an email once that's posted. And appreciate everybody attending today, and have a terrific weekend to everyone.